Unlock the future of pathology with Pathology News, your ultimate source for cutting-edge insights, expert analysis, and the latest breakthroughs in digital and computational pathology. Don't just stay informed, stay ahead.
Hello and welcome to Pathology News. Today we're here back at the University of Warwick for our second appearance here. Last time we were here, we were with Dr Hanya talking about the TIA toolbox, which he developed with his team here. Now today's going to be a little bit different. Today we're talking about OED, that's oral epithelial dysplasia, and the focus today beyond that is going to be on OYDN. Now OYDN, along with the other algorithms that have been developed by the University of Sheffield and the University of Warwick's dentistry teams, and receive funding from Cancer Research UK and NIHR. Now, OYDN, as an example, uses artificial intelligence to help diagnose and support risk stratification for patients with OED. To help us gain a better understanding of what's going on here and the impact that AI is having in this area right now, I'm joined by Dr Adam Shephard, who's the assistant professor here at the University of Warwick, and Dr Hanya Mahmood, who's the senior clinical lecturer and honorary consultant in oral surgery at the University of Sheffield. Pleasure to have you both here.
Thank you.
Thank you very much, for the invitation and for recognising our work and inviting us here.
So, as new members or new guests for our podcast, I was hoping you could tell us a little bit about yourselves and what your role is in this project.
Yeah, brilliant. Thank you very much for inviting us here for this podcast. So my name is Adam Shephard and I'm an assistant professor here within the Tissue Image Analytics Centre, that's within the Department of Computer Science. And a lot of my focus over the last 5 or 6 years at TIA Centre has been working on this project with oral dysplasia and trying to predict using histology slides which cases will become malignant. So I've been very much involved in the design of these algorithms and developing those algorithms. But I'm not actually, in terms of background, I'm not actually a computer scientist by training. Okay. So my undergraduate degree was in natural sciences, so maths and physics at the University of Nottingham. And through that I got really interested in medical imaging, MRI, medical physics, which led me to do my PhD at Aston University. And I did that in developing deep learning methods within paediatric MRI scans to predict outcomes, which then led me to apply to my postdoc over here at Warwick.
Excellent, all very relevant. And Hanya, what about yourself?
So as you've mentioned, I'm based at the School of Clinical Dentistry at the University of Sheffield. I'm an academic oral surgeon. So where I started my involvement in this work was back in 2018 when I was appointed as an NIHR-funded academic clinical fellow, working very closely with Professor Ali Khurram, who's a consultant pathologist, Professor of Pathology and Dean of the School of Dentistry. And I was fortunate to be able to study this area for a couple of years and then receive funding from NIHR to support a doctoral research fellowship and a 3-year PhD, exploring the application of AI, specifically with a focus on oral epithelial dysplasia prognosis prediction. And we've been working very closely as two teams, the TIA Centre here in Warwick and the Neopath team at the School of Dentistry in Sheffield, with Professor Khurram and also with Professor Nasir Rajput, who's been supporting this work and helping lead this work and supervising it. And we've just been working synergistically, I suppose, for about 6 or 7 years together in this area.
It's a long time. So you mentioned a bit about what led you to this subject specifically, but I was hoping you could tell us a little bit about why this project is so important clinically.
Yeah, so oral epithelial dysplasia, as we've discussed, it's a chronic pre-malignant disorder that affects the lining of the mouth, and it can affect any part of the mouth, the lips, the gums, the tongue, the roof of the mouth or the floor of the mouth, and has a statistically increased risk of progression to oral cancer, which is a growing worldwide health problem with increasing numbers and worsening prognosis. And despite health awareness campaigns, and surveillance programs, numbers are still rising and mortality rates are worsening. So one of the best ways in being able to prevent cancer is to focus on the pre-cancer and try and identify and detect that early and accurately so that we can minimise cancer burden and obviously improve patient outcomes. So it's an important topic area, and at the time we started working in this area there was lots of research going on applying AI to study various different types of cancers, but a lot less focus on head and neck cancer and oral pre-cancer in general. So the problem with oral dysplasia is that it's quite a complex diagnosis and it's very difficult for pathologists to give an accurate and reliable diagnosis in terms of its risk for malignant progression. So at the moment the gold standard is we take a biopsy sample or a tissue sample from a patient. We diagnose it by looking at a number of different features down a microscope. And there are so many features that pathologists need to look at. So our current gold standard diagnostic criteria, which is the World Health Organization classification criteria, it grades these lesions into mild, moderate and severe categories based on the presence and the severity and the location of a really wide range of cellular, abnormal cellular and tissue changes. And it's very difficult for pathologists to be able to manually look at every single feature and quantify it. And so there can be variations in interpretation and between pathologists. And that system is not so reliable in being able to indicate which lesions are more likely to become a cancer.
This is where the proactive approach comes in.
Absolutely, yeah. So we know that even mild dysplastic lesions can become cancerous, whereas for severely dysplastic lesions may even regress or may never become a cancer. So there are, various different molecular and biological biomarkers that have been implicated in the progression of dysplasia to malignancy, but none of those have really made it into routine clinical use, and we're still relying very much on histology. And so our work is predominantly focused on the tissue level features. And patient demographic and metadata to be able to try and use that information and combine AI to produce more reliable and consistent and quantifiable outputs for cancer risk prediction.
I mean, you mentioned the gold standard there, but how much variability at the moment is there when pathologists are grading OED?
There can be considerable variability between different pathologists, but also with the same pathologist as well. You could show them a sample and at different time points, and there may be variation in their own interpretation, and that's a subjectivity around diagnosis, and for that reason the WHO classification system is not a reliable indicator or measure of cancer risk. There have been alternative grading systems proposed to try and improve objectivity. So the binary grading system, which classifies these lesions into low and high risk based on the number of abnormal features that are identified. But still, there's lacking kind of robust validation of these models, and so we need new objective ways of trying to improve cancer risk prediction. Yeah, so I mentioned about the subjectivity. So there are a number of reasons for that. Firstly, the current gold standard, there are more than 25 different features that need to be evaluated by a pathologist, and these features are poorly defined, and some of them are quite ambiguous as well, which is what leads to the variation and the differences in interpretation between pathologists. And so there is very little information on which of these individual features are important in cancer development. So in Sheffield, we have published now the first comprehensive histological guide outlining definitions for these different features as a training tool and also an educational tool, and to try and standardise some of these features and what they mean. But also we've looked at we've had a group of pathologists look at the different features in more depth and comprehensively, using digital pathology to look at the prevalence of the different features and different grades of dysplasia, the observer agreement, and also their individual correlation with clinical outcomes, including malignant transformation and also dysplasia recurrence. And what we found was that amongst a very large range of features, there are actually only a small group of features collectively, 6 features we've identified to be more important in cancer risk prediction. And so that kind of led us to develop one of our first models, which is the 6-point model as an alternative system to help with prognosis prediction of dysplasia.
And you said 6-point model there. So why is it a 6-point model?
It's 6 points because it takes into account the 6 features that are shown to be the most important in cancer development and dysplasia recurrence when evaluated by a group of pathologists. And
the main morphological features that are associated.
The key ones, yes, and we studied that, but then we were able to validate that model on independent multicentric data sets to support the fact that that is actually quite a reliable system. And what we did find in the cohort that we studied was that actually it was superior in terms of its prognostic performance compared to the gold standard WHO and also the binary grading system.
Fantastic. And, to move the conversation on then, obviously, we're going to be talking a lot about AI today. So, I have mentioned OYDN already, but Adam, I was hoping you could tell us a little bit about what OYDN is and, how you developed that.
Sure. So OYDN stands for the Oral Dysplasia Network, and it's a deep learning based method that we can use for, it does a few different tasks, but the first task it does is diagnosis. Mm-hmm. So it can take in a whole slide image of oral tissue, and then it will diagnose it as being either OED or normal.
Okay.
And then it will also do various different things. It will segment the epithelium on the tissue and find the dysplastic areas within the tissue, as well as finding all the different nuclei on the tissue.
Yep.
And then it will generate features based on that to predict which of these dysplastic cases become cancerous in the future.
Yeah. Okay. Interesting. And I believe there's been a few different computational pathology approaches to diagnosing this as a set of diseases for OED.
It's part of a larger group of precancerous disorders or potentially malignant disorders, but yeah, specifically dysplasia we know has the potential to progress to malignancy.
Okay. I'm aware that there's a few different computational pathology approaches to OED, but what makes OYDN stand out? Why is it different?
Sure. So in terms of sort of your standard computational pathology pipeline, these are using digital slides that are potentially hundreds of thousands of pixels in each dimension, right? So for a 25 by 75 millimeter whole slide image, slide, this ends up being something about 90 gig worth of data as a digital image. So typically, as a computational pathology pipeline, what happens is we tessellate these images up into smaller images, so of size 500 pixels by 500 pixels instead of that massive image. And then we process each of these patches individually and put them through our deep learning or AI methods and train them. But of course, at the other side, when you try and use these on sort of new cases for prediction, you have to then aggregate this sort of patch level information. And in doing so, you end up losing a lot of the sort of the interpretability and sort of the features a clinician might look at. Okay. So with OYDN, what we're instead doing is we're using deep learning or AI to find different features that we know are important. So they find the epithelium, it finds the dysplasia within the epithelium, it focuses on the dysplasia, and then it looks at the nuclei and it finds features about the nuclei that mimic, say, the World Health Organization grading, and uses those features for this sort of predictive task, as opposed to just these sort of raw image tiles that,
okay. So, this is obviously quite an extensive model, isn't it? So, I'm interested, how did you go about collecting all the data that you needed to train this?
So for this model, we've got about 500 slides that we've trained over. So most of that data is from the University of Sheffield. So we've got from our clinical collaborators. And this is the largest data set of OED tissue slides and outcomes that we know of. So how do we train that? Well, typically within sort of machine learning, you split up your data set into a training and into a test set. And then you train and you develop your models based on this training set. And then you get a test set and you hold it out right until the end and you don't look at it, and then you test it when you've finally developed your model.
Test set, this is data from a location that none of the other data is trained on. None of the algorithm isn't trained on.
Not necessarily. So in the first phase, that will be data from Sheffield that we haven't looked at.
Okay. Yeah.
But in the second phase, sort of this external validation, which is a really important part of testing these algorithms, is where we've got data from different sites. So different sites in the UK. So this includes from Birmingham. we've got it from Belfast, we've also got it from an international partner here in Piracaba Dental School in Sao Paulo in Brazil. And this helps us understand whether these models generalise past Sheffield, for instance.
Yeah, so this is an international collaboration, really. Exactly. Yeah, fantastic. And you mentioned validation there. I want to talk about that a little bit more. How did you ensure that what you're building would generalise beyond a single centre?
Sure. So, well, I suppose there's two different approaches to that. Is that first of all by developing our models that pick out specific features that we know are important for predicting whether OED progresses to malignancy. In a way, our models are agnostic to whether the data is from a different centre or not, because it's still looking at nuclei, it's still looking at tissue types.
Yeah.
But also, we've tried to add domain generalisation techniques that are a set of tools that we can use to try and make sure our models generalise past the domain that we've been trained in, so Sheffield's data. Because of course we know data from Brazil or data even from Birmingham or Belfast might look slightly different, might be stained slightly differently,
and scanned slightly differently.
And scanned slightly differently, exactly. Yeah. So we employed lots of different tools, such as stain augmentation, where you try and replicate some of these different stains and augment them in your training pipeline to try and get around these issues.
Yeah, fascinating. So we talked about obviously the challenges of diagnosis with Hanya. I'm interested. What are the challenges of assembling and harmonising over 500 histology slides, I believe it said in the research paper, from all these different institutions?
Sure. So aside from the core challenges of actually finding all that data, Hanya went and collected all these 500 whole slide images from Sheffield.
Amazing.
But the next stage in terms of me getting the data and trying to process them, of course, quality control is a massive issue because oral dysplasia isn't necessarily a rare disease, but there's often it's hard to get lots of samples, and sometimes the samples don't have much tissue on it.
Yeah.
So, and equally, sometimes the samples have pen markings on. Yeah. Sometimes not the data from Sheffield, of course, but sometimes the slides are dirty.
Top tier, obviously.
Exactly, and it causes a lot of problems in the downstream processing. So we have to do a lot of quality control.
And just to add to what Adam's saying, in terms of, obviously, there's variations in terms of tissue artifacts and the quantity of tissue and the integrity of the tissue and how useful it is. But also there is difficulty in collection of data that is retrospective in terms of clinical metadata associated with these slides. So there may be variations when you're going, back 5, 10, 15 years between different centres in terms of the collection of information such as social history information, smoking and alcohol information, or recurrence data. And so there's a bit of heterogeneity between the different institutions and how data is recorded, and harmonise that data into one data type. So we have been able to optimise the models by including certain types of clinical covariates, things like the site of the lesion and also, the sex and the age of the patient. We've had, slightly more challenges in collecting social history data, for example, and that's probably only really something that can be overcome by prospective data collection.
Let's talk about what this model is really capable of then. How does it support diagnosis? So
the model is able to kind of simultaneously identify areas that are suspicious and dysplastic, classify the lesion and give like a quantitative output which will indicate the risk of that lesion becoming a cancer. So in comparison to our current method of diagnosis, it is a far more consistent and reliable approach using a much larger scale of data that the algorithm's been trained with and obviously validated. And it provides patients, firstly, patients with more quantifiable information to help them understand the risk and counsel them and guide them towards picking the right type of treatment. It's also really useful for pathologists because, although it doesn't there still is an element of a pathologist needing to diagnose the dysplasia, it gives them that additional supportive aid for risk prediction. And that will help them obviously, give an overall pathology diagnosis for the patient. From a surgical and clinical perspective, it will help inform the development of more standardised treatment strategies, which at the moment is variable between surgeons, between institutions and around the world. We treat different lesions invariably because we don't know which ones are going to transform. So there is a lot of benefit in terms of increasing objectivity from a patient, clinician and pathology perspective.
Yeah, absolutely. And this is a conversation that we have all the time, but to talk about and compare this model to the human pathologist diagnostically, how do they compare? Do we see that it's far better than what the human pathologist could achieve?
So yeah, I mean, this is a challenge in how you sort of evaluate these things. But what we did within our work was typically the models that we'd trained would predict whether this case would become malignant or not, for instance, with OYDN. And then we'd, as a baseline comparison, we'd use the pathologist grade, what they'd assigned, the grade they'd assigned, and compare how they predicted, how much either of those predicted, whether the case would transform to malignancy or not.
Okay.
And what we actually found on general was that the AI models fared better and were more predictive of the final diagnosis, the final outcome.
Okay, that's it. That's a result then. Now, we've obviously been here before and talked about the TI toolbox, but I wanted to ask, how was the TI toolbox involved in this project?
So yeah, I mean, it was actually involved pretty much every stage of this project. So for the OYDN project, the OYDN paper, we've released the model code, and you can download it on GitHub or use it on GitHub, and it's used TI toolbox at each stage for each part of the processing. So the toolbox isn't just this sort of suite of algorithms or deep learning algorithms. It's also loads of pre-processing and processing tools as well that we can use. So it's been used pretty much at every single stage.
Yeah, great. Thank you, Adam. And to that end, in the TIA toolbox, you can obviously find information on that from our previous podcast episode, which is on our site. So I believe that OYDN is just not a small part, but some part of the work that the two of you have been doing with your teams. And I kind of wanted to move the conversation on to biomarkers. Could you tell us a little bit about how this project is identifying new biomarkers?
Yeah, so we've identified novel digital biomarkers through the benefits of applying AI. So some of these biomarkers include, we already know that mitosis, the number of mitosis is relevant in dysplasia progression and severity and also cancer risk, but we've been able to identify the fact that actually it's not just the number of mitosis, it's the location of the mitosis and the type of mitosis that actually can influence prognosis. But in addition to that, we've found that the presence and the location and the abundance of immune cells, both within the epithelium and the periepithelium, which is the area just underneath the surface epithelial layer of the tissue sample, also plays a vital role in prognostication of oral dysplasia. So specifically, we've published some work looking at intraepithelial lymphocytes and periepithelial lymphocytes and found that actually an increased quantity of these is associated with reduced progression-free survival and higher risk dysplastic lesions. And we know that there is emerging evidence to demonstrate that the immune microenvironment is important in cancer development and in the increased severity of precancerous disorders. And so it gives us more information about the immune microenvironment that certainly does need to be explored further, and that will help with the development of novel treatment strategies, therapeutics.
So to dig a little deeper on these biomarkers then, how did they emerge as meaningful biomarkers?
Sure, so in terms of these biomarkers, we already expected some of them to be useful because from our clinical collaborators, of course. But then there were some biomarkers that we sort of found to be useful along the way in developing these models. So, for instance, the OYDN model, as I've already discussed, this sort of approach about patching up these images, we can actually generate heat maps that show the most important areas that are useful for the predictive task. And in doing so, we continually found that the heat maps were focusing on certain regions, and these regions happened to be areas that had lots and lots of lymphocytes, whether it was in the epithelium or the periepithelial layer. And so what we then did was we then developed models to actually try and quantify this, and we found out that at the end that these particular types of lymphocytes were predictive of progression, and so that helped us to inform that as such.
Thanks, Adam. I'm wondering then, would it have been possible to do this without AI means?
So we wouldn't have been able to identify these new biomarkers that we've just spoken about without AI and the potential of AI. When I started working in this area, we used digital pathology, digitized images to evaluate the different features. When I spoke about the 6-point model earlier, to identify which of these features might be more important, but it's physically difficult for a pathologist to be able to quantify and analyse some of these features across, such a large cohort just using analogue slides looking down a microscope. So the benefit of AI is that, it not only can extract new, meaningful, biologically meaningful, clinically relevant features, but it can also look across large volumes of data and incorporate other types of data as well, such as clinical metadata, clinical photographs, for example, to strengthen the performance of the model. So it probably wouldn't have been possible in summary, but Adam, you might like to add to that.
Yes, absolutely. A lot of this wouldn't be possible without AI.
Yep.
And so especially sort of the end-to-end nature of the pipelines that we've developed. So for instance, OYDN can take in a digitized whole slide image. It can then diagnose it as being normal or dysplasia, and they can predict whether this case becomes malignant or not. And it does this in a case for about 5 to 10 minutes. So it's fast as well. So you can potentially run these algorithms sort of overnight in the background after they've been sort of digitized.
Fantastic. And to think about why we all do this, ultimately we're trying to help the patient, aren't we? So how will this influence patient outcomes?
It has huge potential to influence patient outcomes. I think first and foremost, patients want information, and they want accurate information to be able to make decisions on their own treatment. And knowing that there is a more consistent, reliable diagnosis given to them and a more reliable risk of cancer development will help them decide what is the right course of treatment. It will also help develop more standardised treatment protocols. And as I mentioned earlier, there's a lot of variation in how surgeons and different clinicians manage and decide which lesions to excise, which ones to monitor, and how you review and do follow-up surveillance for these patients. Of course, we have the potential, if we're detecting dysplasia more accurately and earlier, then we're intervening earlier, and so there will be, reduced morbidity for patients. They may have less symptoms, they may suffer less, and we may be able to prevent new cancer development. So we're reducing cancer burden, both the physical impact of that and the psychological impact of that for patients. And the economic burden to the NHS associated with cancer as well. So we know that there is, a huge expense to the NHS. There's data which shows that actually oral cancer costs annually exceed more than 300 million a year. And in our own unit in Sheffield, there is kind of unpublished data which shows that actually the cost of a single biopsy is about £600. So if we're able to identify the lesion earlier and treat it earlier, then of course we're reducing the economic impact of that as well.
Again, I guess this is going back to the NHS 10-year plan, moving from having a reactive environment to a proactive one. And I think this fits right in, doesn't it, really? So obviously, trust in AI within healthcare is a big topic right now with all these new algorithms coming out. I'm interested from a computer scientist and a clinician's perspective, what needs to happen before a tool like this is trusted in practice?
Sure. So from a computer scientist perspective, I think the stage that we are at the moment with the algorithms that we've developed, they're developed on really large data sets and really varied data sets, but they need to be larger still. We need more data sets. We need to externally validate them on more, not just national centres, but more international centres too, to get more variability into our models and to make sure they'll work past, say, the UK. But of course, interpretability is really important. If clinicians are going to use these tools, they really need to be able to trust what the tools are outputting. And so that's why in the development of these models, especially, say, OYDN, we've tried to sort of make sure that all the features that we're using within the model are features that a pathologist could understand. And also when they're outputting these sort of predictions too, we get these heat maps still that a pathologist can look at it and say, oh, okay, I understand why it's looking at that specific area and why that might be useful for the prediction at the end.
And Hanya, maybe you want to speak to the patient side.
Yeah, so from the patient perspective, of course, trust is a really important thing. And I think, as Adam has already alluded to, being able to demonstrate through evidence and through research that these models have been developed using really large-scale, high-quality data sets, and the accuracy and the strength of prediction outperforming our current gold standard will help instill trust in patients. Yeah. Being able to give patients information about the transparency of these models and advising them that actually their diagnosis isn't just going to be led by a model independently, that actually it's going to be supported by an upskilled, trained pathologist to diagnose first and then use this as a supplementary aid will give them reassurance and trust. And patients are now very much aware of the NHS 10-year plan and the shift from analogue to digital, and so there's greater awareness in general about AI and its use in other things outside of healthcare. So that will help increase trust in general. From a clinical perspective, of course, we've got certain barriers in terms of integration of these models into the NHS workflow. We need to ensure there are robust and established regulatory frameworks in place that take into account the ethics of involving such medical devices in patient diagnosis. There is I suppose a culture shift for clinicians as well to be able to move away from what they know to want to be trained and upskilled in being able to use digital workflows and to receive training in being able to integrate digital systems in their everyday working life. And again, I think evidence and being able to disseminate our research findings and will help consolidate that trust from a clinical perspective. There's obviously fear about being de-skilled and losing out on jobs, and it's just AI doesn't replace the role of a pathologist. Of course, it's a supportive measure.
So obviously, biomarkers has been a big point of discussion today for us. I'm wondering if we could apply the same methodology to other pre-malignant disorders to find new biomarkers there as well. Yeah,
I don't see why not. I mean, we've already done quite a lot of work in trying to see how these methods can be sort of adapted to work in other diseases, such as laryngeal dysplasia. I've also done other work in breast cancer on ductal carcinoma in situ, and using these similar sort of approaches. And in terms of our sort of future directions, we want to sort of expand this past OED and also look to other already potentially malignant disorders to try and expand these methodologies.
Okay, fab. So how will all that be made possible?
This work has been an accumulation of efforts over 6 to 7 years, and we're still working in the space. So we're in the process of applying for funding to expand and optimise our current data sets to further train the models that we've already developed, incorporate other data types to increase the prognostic strength of these models, and go beyond, as Adam has said, beyond dysplasia, looking at the whole range of all potentially malignant disorders and other mimics of dysplasia as well. So there's, we're in the process of working with, increasing number of national and international collaborators, and we've been fortunate to receive funding from Cancer Research UK to be able to digitise our existing data set, which we've developed through the trajectory of work that we've been doing over the past 6 or 7 years, to clean it, to curate it further, to expand on it and diversify it, to hopefully make it available for other researchers and commercial entities to be able to further expand AI application in head and neck precancerous and cancerous lesions.
Great. Thank you, Hanya. And to quiz you on a bit of a timeline perhaps, what will this look like in 5 to 10 years? Where do you think you'll have got to then?
Well, the hope is, I suppose in a decade that this is going to be much closer to the patient and making a primary difference to patient care, and helping change treatment guidelines and reporting and diagnostic grading and classification systems. The work we've spoken about is efforts over a number of years, and we're working on the next stage of the pipeline, which will take us one step closer to patients. There's of course work to be done in terms of regulatory and the ethics behind integration of this as a medical device within the NHS, and so but the hope is within a decade or so that we will be able to improve patient outcomes with the developed models.
Yeah, and just to add to that as well, we had a stakeholder engagement day about 12 months ago, coming towards the end of a lot of the work we've done, and we got charities, patient representatives, we had clinicians, we had other researchers, and the idea was that we disseminated a lot of the findings that we had from these studies, and we also sort of looked at future directions and wanted to see if there was sort of broad clinical agreement about what we wanted to do. And a lot of clinicians, charities, patients were really excited about sort of the next steps.
Yeah.
That's really informed the sort of our plans going forward, hasn't it?
It has, yeah. And we discussed barriers and limitations to clinical adoption of such tools, and from a range of stakeholders. And there's huge interest and positivity, regarding the research and the future directions. And of course, we've taken into account the feedback received from other clinicians and surgeons and pathologists, but also importantly patients, to ensure that any future work addresses those barriers from the onset.
So, we've spoken a lot about digital data sets there and the stakeholder day and, sharing knowledge and information. But, I'm wondering is there anything else you'd like to share with clinicians and, anyone else involved in this?
Yeah, so I think it's important that whilst it's important that we focus on these models being accurate and reliable and giving, better, risk stratification than our current gold standard, but also it's important, and something we will be looking at the clinical utility of these models, how it can be integrated within workflow, within routine clinical practice for pathologists and clinicians in the NHS. Also, being able to measure the impact it has on survival, earlier diagnosis, prevention, and also a cost-benefit analysis and how that would work in terms of integration. This falls quite nicely with the 10-year NHS plan, which we know is focusing on a shift from analogue to digital and transforming healthcare, focusing on earlier diagnosis and prevention to reduce cancer burden. So, it fits nicely with the government priorities for improving patient outcomes.
I hope from this that our audience has got a good insight into how AI can be used in various different computational pipelines, not just OED, but of course the OED work we've done, and how it can also be used to find new biomarkers. And we're also always looking for new collaborators, so if anyone wants to get involved in this project and collaborate with us or contribute new data, then please do get in touch.
I'm just wondering, how can people get in touch with you?
Yeah, sure. So if there's any clinical collaborators that would like to get in touch with us, then there'll be links at the bottom of this podcast, or just look up our names and Warwick and Sheffield respectively.
Well, I think that brings us to the end of today's podcast. Fantastic time, guys. It's been really insightful listening to you about, OED, having a conversation on OYDN. So lastly, I'd just like to say thank you. And I hope our audience have enjoyed this as much as we have as well.
Thank you for giving us the opportunity to talk today. We hope it's useful for the viewers.
Yeah, thank you very much.